Cervical spine as well as whole of the cervical as well as lumbar spine is affected by the rheumatoid arthritis as well as ankylosing spondylitis. As you know that the rheumatoid arthritis and ankylosing spondylitis are systemic diseases. Rheumatoid arthritis is called as rheumatoid arthritis because it affects it's an autoimmune systemic disease. Affects a lot of other joints in our body as well. But when it comes to affecting the spine, the main target or main region of the involvement is always the cervical spine, although it can involve other parts of the spine as well. What is rheumatoid arthritis? As we know, it's actually an autoimmune disease, which is underlying HLA antigen may involve DR4 and DW4 as well. There is actually formation of rheumatoid factor. And how does that forms rheumatoid factor? That actually forms by that initially there is antigen antibody mediated complex formation. Then once that is done, then there is antibody mediated complex formation. Then there is a positive IgM which reacts with the negative IgG to form a complex. This complex actually starts getting deposited into the joints. It can involve around the joints as well, especially in the periarticular region, as well as in the cervical spine as well. Once it starts to develop over there, then there are the mononuclear cells which actually come and target these complexes. And once they come and target these complexes, this leads to bony erosions. That is why when we are seeing the orthopedic manifestation of rheumatoid arthritis, the pathoanatomy is such that there's always initially the complex mediated inflammation, there is invasion of mononuclear cells, and then there is bony erosions, which is specifically marked by periarticular osteopenia, periarticular erosions, as well as the pannus formations. And all this, the necrotic debris, the mononuclear cells, the complex which has been taken up by these mononuclear cells along with the periarticular erosions, they form the pannus, which can mimic a kind of a pathophysiology, which is actually the root cause of all the problem. Once the destruction starts, the bone has been eroded, there is actually weakening of the bone, and then this actually increases the strain on the ligaments and other parts of especially the tendons and the ligaments. When it affects the other joint, this may lead to tenosynovitis and tendon ruptures. But when it comes to the cervical spine, the problem is that the pannus formation has happened in subaxial spine or atlantoaxial part, and most commonly the joint involved is C1, C2, that is the atlantoaxial joint. And once this pannus formation starts, this leads to subluxation because the ligaments cannot hold the bones together because of this. As a result, the classical symptoms of cervical spondylitis, which is seen in the rheumatoid arthritis, are atlantoaxial subluxation, basilar invigilation, and subaxial subluxation. And why this subluxation occurs? For example, if you look at this diagram, this is the C2 vertebra, we have a dens, and this is the C1 vertebra, and this is where the C1, C2 articulation takes place. The most commonly, it's actually attached in a circular fashion. There's a transverse ligament, then there are apical and LR ligaments as well. If you see, this is how it is. The dens of the C2 articulates in a yoke and stick fashion like this. And when this happens, this is actually where the most of the movement occurs in the C1, C2 joints. What happens is that due to this involvement of the bone, there is bony erosions, there is bone weakening. This leads to periarticular osteopenia and erosions. This puts extra stress on the ligaments, and sometimes these ligaments also get inflamed and rupture. As a result, this articulation, instead of happening smoothly, it starts to either the dens goes forward or it becomes backward, especially during the flexion and extension. That is where, when we are measuring the distances, when we are assessing the subluxation in the cervical spine, that is the role of RD, that is anterior atlanto-des interval, and posterior atlanto-des interval comes into play. Because when we are getting the flexion and extension views, we are actually assessing the ligamental stability. And if there is rheumatoid arthritis, there is actually the ligament weakening, or there may be an associated rupture of the ligaments. Along with the bone weakening, this would lead to forward or backward subluxation of one bone over the another. And that is actually we look for. Now, what are the causes? As you know, it's actually, it's not, the problem is not cervical spine. The problem is actually systemic. Rheumatoid arthritis, as you know, it actually involves whole of the body. It can involve elbows, especially the wrist and the metacarpophalangeal joint. It can cause tenosynovitis, tendon rupture, ulnar drift of the head. But we will not be discussing all that over here. We'll be only discussing and focusing on the cervical spondylitis, because there may be associated vasculitis, there may be Felty syndrome association, Still's disease, there may be pulmonary fibrosis associated with rheumatoid arthritis. So all, it's actually a complex problem, but we will only stick to the cervical spine instability and spondylitis, which may be associated with rheumatoid arthritis. What happens is, as I told you, there's a pannus formation. How does that happen? As I've just explained the pathoanatomy, then there is IgM, IgG mediated immune complex deposition. Mononuclear cells come in and try to eat those up, and when they're eating that, this leads to result of periarticular bony erosions and bony weakening. Now this puts extra stress on the ligaments, leading to ligamentous subluxation and even sometimes the rupture of the ligaments as well. This causes, as I told you, erosion of the articular cartilage and loss of subchondral bone, with the destruction and attenuation of the surrounding ligaments, which predisposes to instability. Then there's sometimes subaxial involvement as well, and I will be discussing that when the subaxial involvement occurs, there's actually there may be not that much pannus formation over there, but once the ligaments become weak or torn, the result, a whole vertebra slides over another, leading to translational sort of a problem, and this can lead to complete neurological injury as well. Now, as you know, what are the different types of lesion? There are mainly three different types, which are mainly termed as the atlantoaxial subluxation, which is involving the C1, C2, which is the most commonly involved. Then there may be basilar invagination or vertical subluxation, which is usually seen, or there may be associated with subaxial subluxation, which is below the level of C2. That is, as C1, C2 is supraaxial spine, and C3 and below is always the subaxial spine, and this may involve the subaxial spine as well. Now, coming to the clinical features, as it's a cervical spondylitis, it is a systemic disease. There will be definitely other causes of the symptoms and other systemic problems which will be associated with that patient. There will be, we have to look at the criteria of as well, whether is there any morning stiffness associated with that, is there any involvement of small joints of the head, for example metacarpophalangeal joint, proximal interphalangeal joint and all, is the hands are showing the clear cut ulnar drift and rheumatoid deformities, is there any rheumatoid nodules on the elbow or not. You have to examine the patient as a whole. But when it's involving the cervical spine, then there are specific signs and symptoms which may mimic and which may lead to the diagnosis of cervical spondylitis secondary to rheumatoid arthritis. These include, the most common is the neck pain. Why the neck pain starts? The pannus has been formed, the ligaments are unstable. It's like they're translating and there's subluxation, then coming back, there is slightly instability is there. Now with this instability, there is always a muscle spasm that leads to neck pain. Neck pain is probably the initial symptom, which may be underlying maybe thousands of causes. But sometimes with the patient who have an RA factor positive, you have to look at is it the initial formation of cervical spondylitis or not. Next is movement restriction. Why does that happen? This is very natural, because the muscle have become into a spasm, and this is a tendency of a body to actually stop the subluxation and instability which has been due to the muscle spasm. There may be symptoms and signs of root compression in upper limb. As you know, that if the pannus, once it has started to form, there will be instability, and this would actually lead to progressive instability. There will be a time where it starts to impinge on the root as well. This may result in a root symptoms. For example, radiculopathy symptoms may be present, which may be involving only the one root. They may not be involving other roots as well, especially in the case of subaxial spine. But sometimes the situation, it actually worsens from radiculopathy to further into either it is a myelopathy or other symptoms may come as well. And when the myelopathic symptoms starts to occur, there is involvement of lower limb problems as well. There is problem with the gait, steadiness. Patient is unable to steadily ambulate properly. Then there may be associated upper motor neuron lesions as well, and signs of hyperreflexia in upper motor neuron lesion. There may be associated vertigo as well if there is cerebellar or this is medulla oblongata involvement, but that's usually vertigo. Tinnitus is rare, but it may be involvement of them as well. There may be involvement of visual disturbances, although these signs symptoms are actually usually rare. Then thromboembolic stroke phenomena, because rheumatoid is associated with vasculitis as well, and these immune complex depositions actually deposit themselves in the vessel, leading to proliferation of the endothelium, and this can cause the narrowing of these small vessels of the brain, eventually leading to thromboembolic phenomena and stroke. There will be, when there will be upper motor neuron lesions, there will be definitely positive Hermite sign, which is called as that when you ask the patient to flex the neck, suddenly there is shooting stabbing pain around both of the arms. This may be classical symptom of upper motor neuron lesion associated with cervical myelopathy. Now coming to the clinical features, as I told you, there may be associated muscle spasm, neck stiffness, decreased range of motion, and if you see it over here in the X-ray, you can appreciate there is definitely periarticular destruction. There is periarticular osteopenia. You cannot appreciate the C1 vertebra properly, and you can appreciate the C1, C2. There is a lot of there's slightly anterior deviation as compared to this C2 spinous processes. It may need fixation. For example, if you see it, there's wires have been done just to hold the C1 as compared to the C2. Now this is another formation. If you see it over here, C1, C2 may be okay, but there is definitely subaxial subluxation. Can you appreciate the C4 has been forwardly translated as compared to C5, and C5 is further translated as compared to C6. This is an example of subaxial subluxation in cervical spondylitis as well. Now imaging. Whenever you're suspecting a patient with rheumatoid arthritis, the first and foremost is to evaluate as a whole, because usually cervical spondylitis would not be the only presentation. Then once you have done all the examination and history, after that you go for the x-rays, and on x-rays of the cervical spine we need to get not only the AP view but also the lateral flexion and extension views. Why we need to get flexion and extension views? Because we need to assess the subluxation dynamically. It's not a static problem. There will be no continuous translation or but when the patient will be subluxing or patient will be flexing or extending the neck, at that time there would be some form of subluxation which would be visible on the x-rays. And then we need to calculate the RD, that is anterior atlantoaxial interval and posterior atlantoaxial interval. And now that is something, this is the lateral hyperextension view. If you can appreciate it, the neck is extended in this direction, and in this they only calculate the RD at this level and 6.8 mm. Normal value should be less than 3.5 mm. Why? Because dens of the C2 is actually in the transverse ligament is lying like this, and when the dens rotates, it does not goes forward because there's a transverse ligament. If this ruptures, then there are two LR ligaments which are present over there as well, and then there is a single apical ligament as well. But once transverse ligament ruptures or there is attenuated, this leads to initial subluxation, and RD may be more than 3.5 mm. If it goes more than 7 mm, this means both the transverse and LR ligaments are torn. And when it goes above the 10 mm, this means there is a frank subluxation or dislocation of the C1 over the C2, and that needs correction, especially surgical correction in the case of cervical spondylitis due to rheumatoid arthritis. Then we can go for flexion views. This is the hyperflexion view, and on the hyperflexion view calculate the posterior atlantoaxial interval or the space available for the cord. If you see it over here, this is the part of it. From this is you calculate this much. Normally the space available for the cord is almost 17 mm. It can go beyond, its normal range is from 14 mm to 17 mm. It should not be less than 13 mm. But less than 10 mm, this means there is a lot of narrowing of the spinal cord, and it's an absolute indication to go for surgery, especially if in the case of the rheumatoid arthritis. Therefore, that is why when we are getting the x-rays, normally we get AP and lateral view, but in this case we have to get flexion and extension lateral view so that we can calculate the subluxation which may be there as well. Now, x-rays are not the only modality. We may require the CT scan, and why that is there, because on CT you can easily calculate. Now, this is a kind of an axial view. This is the dens of the C2, this is the arch of the C1. If you can calculate it over here, this is the Atlanto-dense interval of another patient, which is about 5.2, and this is 13.6, as this is the party, that is the posterior Atlanto-dense interval. This is the space available for the spinal cord. So it should be more than 14 to 17 mm. Party should be between this range, and RD should be less than 3.5 mm. Although this suggests that there is some subluxation over then there is relative instability as compared to the normal patient. Now, once we have done the CT is helpful, but we need to get the MRI as well. Why? Because rheumatoid arthritis is not a disease of the isolated of the bones as well. Yes, there is subluxation, yes, there is bony involvement, but then we have to look at whether there is a pannus formation or not, what is the status of the soft tissue around it, and what is the status of the ligaments as well. And if you see it over here, this is actually depicting, you can appreciate there is actually destruction of C1 and C2 dens, and you can appreciate how actually the pannus formation looks like on an MRI. And this is important because when you will be stabilizing this sort of a thing, you need to, because this all eroded bone and necrotic bone has to be removed, all these immune complexes has to be removed. Therefore, you need to fix this, because otherwise this would still be unstable despite the further removal of the pannus. Now coming to the treatment. Treatment is actually to the patient as a whole, and the mainstay of the treatment is still with the rheumatologist. You need to consult and involve the rheumatology department as well, because as an orthopedic surgeon you will be only looking at the orthopedic manifestations, but mainstay of the rheumatoid arthritis is actually the DMARDs, or disease modifying anti-rheumatic drugs, which is usually been administered under the supervision of a rheumatologist. These medications include initially maybe drugs such maybe NSAIDs and steroids may only be given. Then DMARDs may be started as per the consult of the rheumatologist, which may include methotrexate, leflunomide, sulfasalazine, and other drugs as well. And there are new interleukin 1 inhibitors and TNF alpha inhibitors such as rituximab, adalimumab, and Enticept. They may all be available in the armamentarium of the rheumatologist, and as per the consultation of a rheumatologist, we must move with the drugs. Especially once we have controlled the disease, now as an orthopedic surgeon, what you need to look at is whether how much is the instability, and do you really need to fix this, as it is going to create more problems for you or not. Because as a spine surgery, the important point is to save the cord. If it's causing myelopathy, the space available for the cord is around 11 or 12 mm, and in the case of and you know that the further risk formation is going to increase instability, then you may need to fix it. So that is actually the decision. And operative stabilization indications is when there is actually severe unremitting pain. Patient may be feeling the problems of, there may be problems associated with, like for example, patient may come and complain that initially there was only pain, but now there is pain which is increased, plus he or she actually starts fumbling things from her hand. There's an unsteady gait as well. She's unable to ambulate properly. This means now there is an upper motor neuron symptoms which are also coming in. Therefore, you need to assess it that yes, it's going to increase, this instability is going to increase, and do I need to fix it or not. Then neurological signs of root or cord compression. That is the signs of radiculopathy or myelopathy. If they are coming in, then you probably need to go in for surgery and fix it. Presence of deformity or stenosis. And again, if the space available for cord has gone down, is less than 10 mm, then yes, you probably need to fix it. Or presumed presence of instability. We have calculated on the x-rays and the CTs that what is the RD and what is the PADI, and for 3 months back it was good enough values. Now it's coming down, the RD is increasing, then you know that there is a progressive instability, and probably in the next 6 months time it's going to increase further. So to prevent the cord damage, we can go for the fixation as well. Now, what are the different techniques for the stabilization? Usually, what's more important here is to understand what are the different involvements. As I told you, there are three main presentations of cervical spondylitis in rheumatoid arthritis presentation. One is C1, C2 subluxation. Second is basilar invagination. Third is actually the subaxial subluxation. So what is important here is to understand that how much kyphosis or instability is there, and then whether we need to go posterior alone or anterior plus posterior, and that actually depends on the case to case basis. You need to assess the patient and you need to go for surgery, whether posterior alone or posterior plus anterior fixation, depending upon how much translation is there. Some of the techniques which are usually include the Magral technique. This is the classical technique which involves using two screws from posteriorly and fixing the C1 dense with the anterior process of the atlas. You can see it over here. This is going from C2 to C1. Although you can appreciate this definitely periarticular osteopenia, periarticular loss of bone with probably, but fixing this construct would actually lead to, on an AP view, it looks like this, that both the arches are being fixed in this manner. So this is one way of fixing it, so to prevent further subluxation. The other technique is Harm's technique. This is in which actually it's going all posterior, but if you see it over here, the C1, C2 is fixed along with the C3 as well, and then there is further connecting rod posteriorly with instrumentation. So it's actually increasing the construct stability, but only going posteriorly, because the C1, C2 may not be good enough for only fixation. Then you need something, a stable vertebra where you can actually base your construct on, and probably they put it with the screws in the C3 as well. Now, if it is isolated C1 to C subluxation, then we can go for Magral or Harm's technique. But if it is associated with basilar invagination, then you probably need to fix from occiput to C2 as well. That's another form of technique as well, in which they actually put a plate over here in the occiput and they bring it all the down to C2. Now we have covered the C1, C2 subluxation as well as the basilar invagination. The third most common cause of cervical spondylitis is basically the subaxial subluxation. Now if it's involving from C3 and below, then you need to maybe this require fixation at one level, or maybe requiring fixation at multiple levels. So what is important to understand is that you need to restore the stability of the spine. Why? Because to prevent further damage to the spinal cord, as if the spinal cord continues to stenosed due to subluxation, this will eventually lead to from cervical radiculopathy to cervical myelopathy, and eventually leading to problems such as damage to the spinal cord, and will eventually result in a progressive cervical myelopathy, and patient will have a problems with working with hands as well as with the gait abnormalities as well. So you can expect that there will be a lot of problems for the patients if they continue to deteriorate, and eventually they will become bed bound, and then there will be a lot of issues, other issues which may be associated with loss of ambulation as well. That is for the rheumatoid arthritis. Now we will be moving on to the second problem, which is associated mainly in the lumbar spine, that is the ankylosing spondylitis. Again, ankylosing spondylitis is also inflammatory disorder, and it's an autoimmune problem. It involves other areas of the bodies as well, but mainly when it comes to the spine, it involves the lower spine or the lumbar spine as well as the sacroiliac joint. It's an autoimmune disorder which HLA, which is for the B27, which is positive in almost 90% of the patient. And mainly the classical triad of ankylosing spondylitis involves, there's a low back pain, there is sacroiliitis, along with the HLA-B27 positivity, along with the anterior uveitis as well. So there is important when it starts, it also affects our eyes as well, because this leads to uveitis. But what we need to understand is primarily the joint from orthopedic point of view, the main involvement is always the sacroiliac joint. Usually males are more affected as compared to the females, and it's almost the males are 4 times more affected as compared to the females. And what we need to understand is actually disease of third decade. Usually it starts with 22 years, 24 years, 26 years, and that is the time the patient is young, fit, and he or she actually comes and complains of actually the pain in the lower back, and that is the only symptoms initially. And sometimes it may it may take 8 to 10 years to diagnose the patient with ankylosing spondylitis, because usually they're active patients. Then when you dig up the history, they said, okay, we lifted that thing up, we lifted that thing up. Usually are active patients, they're continuously doing their activity. As a result, sometimes it takes a lot of time to actually diagnose that this low back pain is not due to some other form of disc herniation, muscle spasm, or myofascial pain. It's actually due to the sacroiliitis, which is actually occurring at the sacroiliac joint and eventually progressing to this sort of a problem. So there is a problem. Sometimes it takes 2 to 4 years, sometimes it takes 8 to 10 years to diagnose a patient with ankylosing spondylitis, and especially if that patient happens to be a female, because it's very rare in females. So that is why sometimes it takes more time to actually diagnose a patient with ankylosing spondylitis. Now coming to the signs and symptoms of the ankylosing spondylitis. As I told you, classically it presents with three problems, that is the sacroiliitis, HLA-B77 positivity, and uveitis. But there's other different criteria for the clinical assessment, especially of the low back pain as well. This is called as modified New York criteria, which actually assesses the patients with the low back pain and the lumbar sacroiliitis as well. Especially if there is low back pain and stiffness for greater than 3 months, then there is associated with the limited range of the lumbar spine movement, that is flexion, extension, as well as the lateral flexion, as well as the reduced chest expansion. Now, the reduced chest expansion of less than 2 centimeter is very classical of the ankylosing spondylitis. And usually these patients who present with low back pain and reduced range of motion, but there is no chest expansion, less likely to have an ankylosing spondylitis. And in a patient who presents with low back pain and decreased range of motion, one must have to look for the chest expansion in these patients as well. Now coming to the clinical features, as I told you, by the time now you would have realized is how would a patient would present with the ankylosing spondylitis. Usually it's a young patient, preferably more commonly it is in males, and usually in the third decade, 25, 26, 28, these are the usually years. This may present with neck pain and stiffness if it's involving the cervical spine, as it can involve the cervical as well as lumbar spine, but most commonly it involves the lumbar spine as well. There may be increased kyphosis. Due to increased cervical spine kyphosis, the patient may have a kind of a, the neck may be flexed, and a patient may not be looking like this, because you can expect a patient looking like this because the patient is unable to hold his head up because of the kyphosis of the cervical spine. And this deformity, when a patient comes and looks like this, is called as a chin on chest deformity. It may be associated with the compression of the horizontal gaze. The patient may not be able to look up over the ceiling, or may not be able to see what's in the above the top of the wall. There may be associated swelling and jaw opening, because there may be because it's basically a problem of enthesitis, that is enthesis got inflamed. Now enthesitis means this is an interface between the ligament attaches to the bone or tendon attaches to the bone. If there is an inflammation over there, there will be definitely a lot of problems with the joint movements, and patient may have a locked jaw or a swallowing problem of the opening the jaw as well. There will be restricted spinal movements which may involve especially the flexion and extension of the spine, and lumbar lordosis may be quite much affected as well. So when you get an X-rays, you need to differentiate ankylosing spondylitis from another disease called the DISH, RDISH, that is the diffuse idiopathic skeletal hyperostosis. And why? Because it's kind of affects the spine the same way, but you need to logically differentiate from DISH as well. So therefore, you have to understand that if a patient does comes of ankylosing spondylitis, then you have to rule out whether this patient may be having the same clinical picture, but may be having a DISH rather than having ankylosing spondylitis. If you get an X-ray, what do you see over on this cervical spine X-ray? If you see the lateral view clearly, This is, you can see there is definitely calcification of the vertebral end plates. This actually shows a bamboo spine. The classical presentation is there is a bamboo spine formation in ankylosing spondylitis. This is involvement of the disc space. You can appreciate there's some calcification of disc space as well as there is anterior syndesmocyte formation. If you see it over here, this is where the syndesmocyte has been formed. What is the syndesmocyte? It's actually enthesitis inflammation of the anterior longitudinal ligament, eventually gets calcified and it starts to join and looks like a bony bridge. Actually it's sort of a bony bridge plus ligamentous inflammation, as well as this form the syndesmocyte. This is the actually the vertebral end plates unite of one vertebra when above and below. This leads to syndesmocyte formation. So this is where the difference between the dish and the ankylosing spondylitis comes in, because the dish usually does not involve, there will be no bamboo spine over there, there will be no involvement of the disc, and there will be diffuse hyperostosis, but there will be no marginal syndesmocyte formation as compared to ankylosing spondylitis. Further continuing, if you see it over here, this spine is not showing that sort of a if you can appreciate it over here, there is not a lot of calcification, but can you appreciate there is slight hyperostosis over here along with the fracture of the cervical spine. Now this is very important, especially when we are reviewing a patient, especially who had an ankylosing spondylitis, who was diagnosed case of ankylosing spondylitis and has a trauma, because that is where we need to look for it, because sometimes the x-ray may be absolutely normal despite having a cervical spine fracture in these patients. And when you get a CT over here, this is the kind of a picture, and now you can appreciate more. There is calcification along with the anterior syndesmocyte as well over here and here, as well as the fracture of the C2, 3, 4 and C5 vertebra. You can appreciate it over here, and look at this, looks like very normal, maybe a slight break over here, but there's definitely a fracture involving the whole of the body of the C5. And this is what it looks like on the CT, and that is where the role of CT actually comes in. And although usually CT may not be required in normal settings, X-ray is very much evident, with a clinical picture may be evident. But if a patient who is diagnosed case of ankylosing spondylitis comes with a history of a fall, patient was having, because usually these patients, once they get diagnosed, they may be having a very active lifestyle around 40, 50, and for example patient has a history of a fall in which he banged his or her neck or a head somewhere, and on x-rays, then on clinical examination there is mild tenderness and pain, but x-ray of the cervical spine may be absolutely normal. In that case you need to rule out the fracture, which may not be very well visible on the normal x-ray because increased calcification and syndesmocyte formation. And this is when you get a CT, this is what you see. This you can see a big fracture which is evolving through the syndesmocyte going all the way back into the body as well. And that is why it's important to get a CT, especially if the patient comes to you with a case history of trauma, who is a diagnosed case of ankylosing spondylitis. Now coming to the treatment. Now again, understanding this point is important, that it's not a purely spine disease. It does not purely involve the spine. It may involve the sacroiliac joint as well. It may involve the hip joint as well, and there may be associated avascular necrosis as well, the both hip joints. Then it can involve the cervical spine, the lumbar spine, as well as other areas of the body as well. For example, there may be associated systemic manifestations, like there may be renal amyloidosis, there may be associated pulmonary fibrosis, there may be associated aortic vasculitis, or there may be associated uveitis of the eyes as well. So it's depending upon that what is the presentation of the symptoms, you need to get opinion or consultation of a pulmonologist, nephrologist, as well as an ophthalmologist as well. But talking about the orthopedic manifestation of ankylosing spondylitis, it usually involves the bamboo spine, there's enthesitis, the syndesmocyte formation, along with the classical progressive cervical kyphosis. And initially, once the patients starts having problem with the low back pain, decreased range of motion, then you can start off with initially conservative management. That is the form of, you can give them non-pharmacological treatment, could include regular exercises, physiotherapy, especially the aggressive physiotherapy, so that the muscle spasm can be reduced. Then we can move to the pharmacological treatment that may include NSAIDs. For example, initially it may have to be given for just the pain management along with the physiotherapy, because it's very initial stage of the disease and you know you need to just stop the quick progression of it. Along with analgesics, glucocorticoids may be administered as well. Then you need to get opinion of the medical personnel as well, because there will be associated pulmonary fibrosis, renal amyloidosis as well. Then anti-rheumatic drugs like DMARDs may also be given in these patients. Especially the TNF alpha inhibitors have a very pivotal role in the treatment of pain, especially associated with ankylosing spondylitis, or anti-tumor necrosis factor therapy, anti-TNF, as I just told you. And then you may require a reduced radiographic progression. What we need to do is that although you know it's a systemic autoimmune disease, you cannot reverse it back, but yes, you can halt the progression, and that is what we need to do. You need to halt the progression, further aggravating the problems. Now coming to the surgical treatment. Surgical treatment depends where the problem is. If there is a lot of kyphosis of the cervical spine, patient comes to you with this is the problem and I cannot look up, then probably you need to do something. This is a classical chain of chest problem, and if that is happening to the patient, then something needs to be done, especially surgically, to correct the kind of a kyphosis of the cervical spine. If you see it over here, this is a massive kyphosis. It should have been, the usually normal curvature is in lordotic curvature of the cervical spine, but it's going into a lot of kyphosis. So you need to go for some form of an osteotomy to correct this problem. Now, osteotomies could be multiple options are available. Just to name few, one is called a Smith-Peterson osteotomy. Then is posterior pedicle subtraction osteotomy. Then there is vertebral resection osteotomy. So SPO, PSO, and VRO, depending upon how much is the pathology, how much is the kyphosis, how much correction is required in the kyphosis, then consultant and an orthopedic surgeon can decide what type of osteotomy I need to do. Then what is important is that you need to understand that do I need to take out the vertebral disc or not. If to correct this kind of a kyphosis, you need to take out because there's a massive kyphosis, then you need to take out, probably would require a more vertebral resection osteotomy. But if the vertebral disc is not needed, there is mild kyphosis, then both the Smith-Peterson and posterior pedicle subtraction osteotomies can be performed. And after the performing the osteotomies, you need to fix it like this. Now fixation could be at multiple levels and with or without instrumentation, because what is important is you need to stabilize, because if you, after doing the osteotomy, you cannot leave it as such, and you cannot just fix one or two levels, because otherwise other vertebra which are above and below this level are going to be at increased stress, and they are gonna subluxate and create problems for the spinal cord. So therefore you need to fix it properly so that the spine becomes more stable. Now we have covered mainly the two problems of the cervical spine, especially the lumbar spine as well, and which are both basically the autoimmune diseases which involve other parts of the body as well. If we are talking about rheumatoid arthritis, it mainly causes atlantoaxial subluxation, basilar invagination, subaxial subluxation. We need to understand that it's not an isolated disease, it is a complex problem. We need to involve a rheumatologist, other physiotherapists, and others involvement as well. If it comes out to be dealing with the spine problem only, then we have different options, whether depending upon how much subluxation is there. If there is, we have to calculate the RD, we have to calculate the PARD and assess the clinical effect which is happening on the patient as well. If there's a lot of myelopathy, then probably we need to go for some form of a fixation, which could be in form of a Harms construct, or it could be in form of a Magret technique as well. Or then we need to do the occiput to C2 fusion as well. Now coming to ankylosing spondylitis, again, it's an autoimmune disease. You need to analyze the patient from a medical point of view as well. This may be associated with renal amyloidosis, pulmonary fibrosis, aortic vasculitis, anterior uveitis as well. So what you need to know is that you need to involve other specialties as well, from like ophthalmologist to medical specialist to nephrologist to pulmonologist as well. And once you know them, you need to get their opinion as well. It's a systemic disease, so we have step-wise approach has to be taken. Initially, we can give pharmacological treatment such as NSAIDs, analgesics, and simply the glucocorticoids as well. There is a role of some form of role of DMARDs as well as anti-TNF alpha inhibitors as well, along with the regular physiotherapy and exercise program so that we can halt the progression. But once the kyphosis goes beyond a certain limit, there where it starts to affect actually the spinal cord and there may be signs and symptoms of root involvement or cervical myelopathy, then probably we need to intervene surgically, especially in the case of spine. And that may involve multiple forms of osteotomies depending upon how much kyphosis is there. We can go for Smith-Peterson osteotomy, pedicle subtraction osteotomy, or even vertebral resection osteotomy as well. Thank you very much. Keep watching sqadia.com.